Endoscopic submucosal dissection for early gastric cancer. Are expanded resection criteria safe for Western patients? Introduction. Endoscopic resection is widely accepted as a treatment option for early gastric cancer, EGC, with negligible risk of lymph node metastasis, LNM. Endoscopic mucosal resection, EMR, is a well-established technique for the removal of gastric neoplasia. However, en bloc resection with conventional EMR is restricted to lesions with a diameter of 20 mm or less. Endoscopic submucosal dissection, ESD, has been developed to overcome this problem and allows en bloc resection of lesions regardless of their size. In the 1990s, the Japanese Gastric Cancer Association addressed the technical limitations of EMR by defining guidance criteria for endoscopic resection. EMR was judged adequate in elevated EGCs of less than 20 mm in diameter and in depressed EGCs of up to 10 mm. Further criteria were histology of differentiated adenocarcinoma, absence of ulceration, and absence of submucosal, lymphatic, or vascular invasion. However, in 2000, Gotada et al. Showed that these criteria might be restrictive and that too many patients might be unnecessarily treated by surgery, with higher risk of morbidity and mortality. Based on the analysis of more than 5,000 EGCs, the resection criteria were then redefined. These expanded resection criteria allowed endoscopic resection of larger lesions, small ulcerated lesions, and small lesions with minute submucosal invasion. Further data from Asia demonstrated a very low risk of LNM for small intramucosal undifferentiated type EGCs. The ESD technique made en bloc resection of expanded criteria lesions possible, and large studies showed en bloc and R0 resection rates exceeding 90% for ESD in EGCs. Long-term follow-up data demonstrated excellent overall survival and recurrence-free survival rates, which were comparable for guideline criteria and expanded criteria lesions. Based on these data, ESD is accepted as the treatment of choice for EGCs meeting either the guideline criteria or the expanded criteria in Asia. However, ESD is technically difficult and time-consuming with a slow learning curve, especially for Western endoscopists. Western data on gastric ESDs are limited and, owing to the lower incidence of EGCs in Europe, studies are small compared with Asian data. Recently, European authors confirmed the advantages of ESD regarding high en bloc resection and R0 resection rates, low recurrence rates, and tolerable complication risks in the Western setting. However, Western long-term data are lacking, and there is an ongoing debate about whether Asian resection criteria can be simply transferred to European and other non-Asian patients. In contrast to Japanese data, Hulscher et al. Described a risk for LNM of 13% for EGCs invading the deep mucosal layer and 21% for submucosal invasive EGCs in Germany. Today, the role of endoscopic resection for EGCs fulfilling the expanded criteria is debated controversially between gastroenterologists and surgeons in Europe. Based on this debate, different recommendations are given in European guidelines. The European Society of Gastrointestinal Endoscopy recommends endoscopic resection for EGCs of guideline criteria and expanded criteria, whereas the European Society for Medical Oncology and the German Society of Gastroenterology give restrictive recommendations, allowing endoscopic resection for lesions meeting the guideline criteria and recommending surgery for lesions fulfilling the expanded criteria. The aim of this study was to present data on ESD for EGC in a European cohort, with a special focus on long-term follow-up after resection of lesions meeting the guideline and expanded criteria, respectively. Background and study aims. Endoscopic submucosal dissection is the standard treatment for early gastric cancer, EGC, fulfilling guideline resection criteria or the expanded resection criteria in Asia. It is unclear whether the expanded criteria can be transferred to European patients, and long-term follow-up data are lacking. The aim of this study was to evaluate long-term follow-up data after ESD of EGCs in Europe. Patients and methods. Patients with EGC who underwent ESD were included in this single-center study at a German referral center. Patient and lesion characteristics, procedure characteristics, and follow-up data were recorded prospectively. Results. A total of 179 patients with 191 EGCs were included over a period of 141 months, with 29.6% of lesions meeting guideline criteria and 48.6% meeting expanded criteria. The en-bloc resection rate was 98.4% for guideline criteria and 89.0% for expanded criteria lesions, p equals 0.09, and the R0 resection rates were 90.2% and 73.6% respectively, p equals 0.02. The main reason for the expanded criteria was a lesion diameter greater than 20 millimeters, 81.6%. Complications: perforation 1%, delayed bleeding 6.3%, stricture 2.1%, procedure-related mortality 1.1%. Local recurrence rate was 0% for guideline criteria and 4.8% for expanded criteria lesions, p equals 0.06, and the rates of metachronous neoplasia were 15.1% and 7.1% respectively, median follow-up 51 and 56 months, respectively. 92.9% of metachronous neoplasia were treated curatively with repeat ESD. One patient developed lymph node metastasis after ESD of a submucosal invasive expanded criteria lesion. Long-term survival was comparable between the two criteria, p equals 0.58. No gastric cancer-related death was observed in either group. Conclusions: ESD can achieve high rates of long-term curative treatment using the expanded criteria in EGCs in Western countries. The authors recommend ESD as the treatment of choice not only for guideline criteria EGCs, but also for intramucosal non-ulcerated EGCs regardless of their diameter.